I am Dr. Saqib Mansoor, and this is my channel, Learning Anatomy for You. And today I will discuss a very important topic of anatomy, the shoulder joint, right? It is also called as the glenohumeral joint. It is formed between the glenoid cavity. Here you follow the laser glenoid cavity of the scapula and the humeral head of the humerus. Here you can see this. And first I will give you a concept of the shoulder girdle. Here you could see this is the shoulder girdle with these four joints and three bones involved over here. The four articulation of joints are number one, sternoclavicular joint. Here you could see this is the sternoclavicular joint between the sternum and the clavicle, right? This is the sternoclavicular joint. And number two, this is the acromioclavicular joint between the clavicle and the acromion of the scapula. This is the acromion of the scapula. And number three is the glenohumeral joint. This is today's topic, the glenohumeral joint or the shoulder joint between the head of the humerus and the glenoid cavity of the scapula. And number four is the scapulothoracic joint. This is not an anatomical joint, scapulothoracic joint, and I will tell in a while what it is, scapulothoracic joint. Three bones are involved, which is number one, clavicle, number two, this scapula, and number three, this is the humerus. So I mentioned one thing, this scapulothoracic joint. It is not an anatomical joint, as it does not refer to two opposing bones. Instead, it is a physiological joint of the pectoral girdle. It is constituted by the convex surface of the posterior thoracic cage and the concave surface of the anterior scapula, right? You could see this. This is the scapula, and here the convex surface of the thoracic cage would be involved. These articulations enable the shoulder girdle to allow a large range of motion for the hand to move maximally in space. Large round head of the humerus articulates with relatively shallow pear-shaped glenoid cavity of the scapula. I've shown you already this picture. There is approximately 4:1 disproportion between the large round humeral head and the small shallow glenoid cavity of the scapula. Glenoid labrum, Latin, labrum means lip. A ring of the fibrocartilage is attached to the margins of the glenoid cavity, which deepens slightly but very effectively the depression of the glenoid fossa. You could see again in another picture. It's a beautiful picture, right? This is the head of the humerus and this is the glenoid cavity. This is four times head of the humerus is 4 times larger than the glenoid cavity, this shallow one. Glenoid cavity is shallow of the scapula. Here you could see this, right? This, and this is the glenoid cavity of the scapula, and this is a head of the humerus. And here you could see this fibrocartilaginous rim attached to the margins of the glenoid cavity. This is known as the glenoid labrum. So both articular surfaces are covered with hyaline cartilage, right? These are covered with hyaline cartilage. Glenoid cavity accommodates little more than a third of the humeral head, which is held in the cavity by the tonus of the musculotendinous rotator cuff, right? So another concept, as the cavity is this shallow, and this is the glenoid labrum, and this shallow cavity accommodates this larger head, and it is assisted by this hold up is assisted by the rotator cuff. So let's talk about the rotator cuff or the musculotendinous cuff. Rotator cuff is the name attributed to the tendon of the sits muscle, small t is for teres minor. Let's take this beautiful picture of this, right? You could see this. Sits. S is for supraspinatus. You could see this is the supraspinatus muscle, superiorly lying to the shoulder joint here. And this is the infraspinatus muscle, and this is the teres minor muscle, right? And this is anteriorly lying is the subscapularis, right? This is the subscapularis attached to the lesser tubercle, right? And these four tendons are fused with the joint capsule of the shoulder joint, and they support it upwards and the posteriorly and anteriorly. And you note even here that inferiorly, this rotator cuff is deficient. So this is the weaker part of the joint. You could see a spot the rotator cuff muscle over here even. Yes, this is, I enlarged it for you, right? Zooming in. Here you could see this is the supraspinatus. Here you could see this is the supraspinatus muscle. Then this is the subscapularis in this side. And then on here, this side, right side and the left side. Then is the infraspinatus. This is the infraspinatus. And this is the teres minor. So continuing, loose fibrous layer of the joint capsule, right? Talking about the joint capsule, it surrounds the joint and is attached medially to the margin of the glenoid cavity and laterally to the anatomical neck. Let me show it to you, right? So this is the fibrous capsule. You could see this. Yes, this structure. This is the fibrous capsule. You follow the laser. And this hand, and this is the fibrous capsule and attached medially to the margins of the glenoid cavity. These are the glenoid cavity, this and this is its margin. It is attached here and below to here you could see here, right here. This is the point where the hand is, right? This is the below margin of the glenoid cavity, and this is the medial attachment. And laterally, the capsule is attached to the anatomical neck of the, this humerus, right? This over here. And superiorly, this part of the capsule encroaches on root of the coracoid process, such that the fibrous layer of the capsule surrounds the proximal attachment of the long head of the biceps brachiae to the supraglenoid tubercle of the scapula within the joint. Here you could see again, this is the tendon of the long head of the biceps. The same picture, yes, you could see over here, rightness. Even I zoom into this picture for clarity. Yes, you could see this. This is the tendon of the long head of the bicep, and this is intracapsular, right? This is intracapsular, right? And this fibrous layer of the capsule encroaches on the coracoid process, and it encloses this origin of the tendon of the long head of the biceps. It's a supraglenoid tubercle. So let's talk about, there are the two apertures are present in the joint capsule. Here is this one, and this is number 2, right? So I think so I better zoom in that, right? You could see this. This one aperture is for the tendon of the long head of the biceps brachiae, where is a synovial sheath is present around it, right? So it comes out of it, and this is an aperture in the joint capsule. And second is aperture for the subtendinous bursa of the subscapularis. Here, this is below the coracoid process, this aperture. And joint capsule of the shoulder joint continues. Inferior part of the joint capsule is its weakest area, as it is the only part not strengthened by the rotator cuff muscle. I already shown you and discussed in the picture. Rotator cuff muscle is not strengthening it in the inferior part. Here in the inferior part, capsule is particularly loose and lies in folds when the arm is in adducted position, though it becomes tight when the arm is in abducted position. That is why the dislocations of the shoulder joint are mostly in the inferior part. You could see this, right? This is superiorly and posteriorly and anteriorly. This is these four muscles, the rotator cuff muscles, are strengthening the joint capsule, and inferiorly they are absent. This rotator cuff is not present, right? So the synovial membrane, right? Synovial membrane lines the internal surface of the fibrous layer of the capsule and reflects from it to the glenoidal labrum and the humerus as far as articular margins of the humeral head. So let's zoom in. You could see this over here, right? So you could see this is the synovial membrane, this pinkish color lining the inner side of the fibrous capsule over here, right? You could see over here as well. This is a fibrous capsule, and this is a synovial membrane lining. These are the reflections over here and the here, as I discussed with you. Synovial membrane constitutes a tubular sheath for the tendon of the long head of the biceps brachii, whereby it is placed in intertubercular sulcus of the humerus and passes into joint cavity. Here I told you it is. Again, I enlarge it for you. It's always a better option to enlarge the pictures for a better concept, the crystal clear concepts. Right, this is tendon of the long head of the biceps, and it is a synovial membrane, right? And this is the synovial sheath, right? So a tubular sheath is formed around the tendon of the long head of the biceps brachii by the synovial membrane. So it communicates within the joint. So this is the tendon of the long head of the biceps brachii, is intercapsular. Synovial membrane extends through the interior wall of the capsule to constitute subscapularis bursa beneath the subscapularis muscle, right? So here you could see this is the other bursa, and I also prefer to zoom in that over here. This is the subtendinous bursa of subscapularis over here, right? So there are two of these openings in the bursa. So now, very important, ligaments of the shoulder joint. These are intrinsic ligaments, first of all. This means that these are the part of the fibrous layer of the joint capsule. First of all are the glenohumeral ligaments. You could see here, these are the glenohumeral ligaments. I will enlarge in a very short while. And then is a coraco-humeral ligament. This is the coraco-humeral ligament, strengthening joint capsule. This strengthens this superiorly, right? So let me enlarge it for you over here, same, right? So these are the glenohumeral ligaments, right? They are in fact superior, middle, and inferior over here, right? And this is a coraco-humeral ligaments present superiorly, coraco-humeral ligament. Glenohumeral ligaments, 3 fibrous bands, conspicuous only on the internal aspect of the joint capsule. This is the internal opened view of the shoulder joint, and I will show these 3 ligaments straight away very soon to you right now, rather, right? Let's have a look at that, right? These are 1, 2, and 3. These are the 1, 2, and 3. These are the glenohumeral ligaments, superior. This one is a superior. This is a middle. 2 and 3 is inferior, right? You could see, and their attachment to the labrum, right? This is the labrum here, right? Yes, you could see this, right? This is a glenoid labrum over here. This thing, glenoid labrum, right? So they are going laterally and inferiorly. Laterally and inferiorly from glenoid labrum at the supraglenoid tubercle of the scapula, and these blend distally with the fibrous layer of the capsule where it attaches to the anatomical neck of the humerus. So coraco-humeral ligament, right? Coraco-humeral ligament. This I told you, this is the coraco-humeral ligament. This from the coracoid process to the humerus. From the base of the coracoid process, it projects to the anterior aspect of the greater tubercle of the humerus, right? I enlarge it for you again. Right? You could see this. This is the coraco-humeral ligament over here, this coraco-humeral ligament, and this is from base of the coracoid process. It goes to the, this humerus tubercle. And then the transverse humeral ligament is a broad fibrous band that runs more or less obliquely from the greater to the lesser tubercle of the humerus and reaches the intertubercular sulcus, right? This is the transverse humeral ligament, right? You could see this. Transverse humeral ligament converts the intertubercular sulcus into a canal, which holds the synovial sheath and the tendon of the biceps brachii in place during movements of the shoulder joint. So very, very important, this coraco-acromial arch. This is the coraco-acromial arch number 1, 2, and 3. So I mean, let's spot it out first, then we'll talk about it. So what are the three components of the coraco-acromial arch, right? So number 1, this Coracoid process is a part of the coraco-acromial arch. Coracoid process, and number 2, this is the acromion, and this number 3 is the coraco-acromial ligament. Coracoid process, coraco-acromial ligament, and the acromion, and this whole thing is the coraco-acromial arch. Right, it is a secondary socket of the shoulder joint, and it supports it. It's a very big support of the shoulder joint. This osteoligamentous structure constitutes a protective arch. I told you already that overlies head of the humerus, thus preventing its superior displacement from the shallow glenoid cavity. Coraco-acromial arch is enormously strong, such that a forceful superior thrust of the humerus does not fracture it. Rather, humeral shaft or the clavicle fractures first. This is already, right? This is the number 1, 2, and 3. This is the coraco-acromial arch, lying superior to the shoulder joint, and it prevents it the dislocation, superior dislocation of this humeral head. So ligaments continuing transmitting force in upward direction along humerus, for example, while standing at a desk and partly supporting the body with outstretched limb, the head of the humerus presses against the coraco-acromial arch. The supraspinatus muscle passes below this arch and is placed deep to the deltoid as its tendon fuses with the joint capsule of the glenohumeral joint as a component of the rotator cuff. So here you could see this is another beautiful picture, right? So this is, this is the supraspinatus muscle, right? Supraspinatus. And you note over here, this is a subdeltoid subacromial bursa, right? This is the bursa, subacromial, and below that is the supraspinatus muscle. This is the one of the rotator cuff muscle, the supraspinatus, and it blends with the joint capsule over here, right? So the movement of the tendon of the supraspinatus as it attaches to the great tubercle of the humerus is facilitated as it passes below the arch by the subacromial bursa. I've shown you already, will show you again, which lies between the coraco-acromial arch superiorly and the tendon of the tubercle inferiorly, right? You could see again the zooming in for a better concept. Yes. So this is, subacromial bursa, this is supraspinatus, and above that is the deltoid and acromion, right? And this is the position. So stability of the joint, very important, very, very important, maintained by the factors given below. As this is a very, very mobile joint, and one of the, I think I tell you, this is the most mobile joint of the body, right? And of course, when there is that much of the mobility is provided at the cost of the stability. Stability is compromised, but still it is maintained by these factors given below. Coraco-acromial arch, secondary socket for the humeral head, all shown you already. Rotator of the musculotendinous, cuff of the shoulder, glenoid labrum, and number 4, the muscles that attach humerus to the pectoral girdle, long head of the triceps brachii and the long head of the biceps brachii. And in addition, pectoralis major, latissimus dorsi, teres major, and deltoid also act to stabilize the joint. Atmospheric pressure is also regarded as a stability factor. So stability continues. This is the rotator cuff muscles. The tone of the rotator cuff muscles assist in holding the head of the humerus in the glenoid cavity of the scapula during various movements at the shoulder joint. The cuff is placed on the anterior, posterior, and superior aspects of the glenohumeral joint. So the cuff is not present inferiorly, thus making it a site of the potential weakness. I've mentioned this point very, many times. Humeral head is much larger than the glenoid cavity, and the joint capsule, though strong, is very loose. It suggests that the shoulder joint is an unstable joint. Of course, why this capsule is loose? This is loose because to allow and permit a wide range of the movements. However, there are factors that contribute to the stability include This is, strengthening of the capsule by fusion with the tendon of the scapular muscles, coraco-humeral and glenohumeral ligaments, suprahumeral support provided by coraco-acromial arch, deepening of the glenoid cavity by the labrum, and the splinting effect of the tendon of the long heads of the biceps and triceps above and below the head of the humerus. So upward displacement of the humeral head is prevented by the overhanging coracoid and the acromion processes and the coraco-acromial ligament that bridges them. The whole constitutes a coraco-acromial arch. I have discussed it already with you. Arch is very strong. This I've told you already. So this is now the relations of the shoulder joint. Very easy, very simple. So let me enlarge this picture for you, right? This is there with it, is right. So here I go, this to the point, and this is, first of all, anteriorly is the subscapularis muscle, right? Subscapularis. Here you could see this. This is the over here. This is the subscapularis. Anteriorly is the subscapularis, right? And posteriorly are the infraspinatus and the teres minor. And let's go superior. Superior are the supraspinatus and the subacromial bursa, and over these is the deltoid and this coraco-acromial ligament, right? These are the superior relationships. And then inferiorly, long at the triceps muscle and the axillary nerve and the posterior circumflex vessel. This is the long end of the triceps, which you could see here. The tendon of the long end of the biceps passes through the joint and emerges beneath transverse ligament. So, very important movements of the shoulder joint. Almost all movements taking place between humerus and the glenoid cavity at the glenohumeral joint are accompanied by an appropriate movement of the scapula itself. Then the scapula cannot move without making its supporting strut clavicle move too. These three joints of pectoral girdle, the glenohumeral joint, the acromioclavicular, and the sternoclavicular, move together harmoniously, thus yielding a kind of thoracohumeral articulation. Defects in any component of this thoracohumeral articulation impairs the function of the whole. So the shoulder joint is more mobile than any other joint in the body. I told you already, this freedom is due to the loose nature of the joint capsule and the large size of the head of the humerus compared with the small size of the shallow glenoid cavity. The multi-axial shoulder joint permit movements around 3 axes and allows flexion and extension, abduction and adduction, rotation, which is medial rotation and lateral rotation of the humerus, and the circumduction. So following movements take place and the muscles involved are mentioned. This is the flexion. You could see this arm going ahead and in front of the chest. And this is extension, arm coming back from the behind the chest. Normal flexion is about 90 degree. This is the flexion 90 degree and is carried out by the anterior fibers of the deltoid, pectoralis major, clavicular head, coracobrachialis, and the biceps brachii muscles. This is extension, right? Normal extension is about 45 degree and is carried out by the posterior fibers of the deltoid, teres major, and latissimus dorsi muscles. It is assisted by sternocostal head of the pectoralis major, long head of the triceps. Now the abduction and adduction, very interesting, this mechanism and this abduction process, right? A lot of muscle and ranges involved. Abduction of the upper limb takes place both at the shoulder joint and between scapula and thoracic wall. That is scapular-humeral mechanism. Middle fibers of deltoid along with supraspinatus get involved, right? So supraspinatus initiates movement abduction, right? 0 to 15 degrees and holds the humeral head against the glenoid fossa of the scapula. The later function permits the deltoid to contract and abduct the humerus at shoulder joint. So this is the summary of the muscles causing abduction. Supraspinatus is 0 to 15, deltoid is 15 to 90 degree, and also the serratus anterior from 90 degree to 180 degree, and very important, upper and lower fibers of the trapezius 90 to 180 degree. So now coming to the adduction, right? So adduction, normally upper limb can be swung 45 degree across front of the chest. This is carried out by the pectoralis major, teres major, latissimus dorsi, and teres minor muscles. Long head of the triceps, short head of the biceps, brachii, coracobrachial are also involved. These are the muscles of the adduction, I tell you. Lateral rotation, right? This is a lateral rotation. Normal rotation, lateral rotation is 40 degree to 45 degree, carried out by the infraspinatus, teres minor, and the posterior fibers of the deltoid. And this is a medial rotation. Normal medial rotation is about 55 degree, carried out by the subscapularis, the teres major, latissimus dorsi, and the interior fibers of the deltoid. Pec major and the subscapular are also involved here. So circumduction at the shoulder joint, this is an orderly sequence of the flexion, then the extension, flexion, and then abduction, then the adduction, right? Or the reverse. Now, very important and interesting, the scapular-humeral mechanism. What is that? The scapula and the upper limb are suspended from the clavicle by the very strong coraco-clavicular ligament, aided by the tone of the muscles. When scapula rotates on the chest wall, so the position of the glenoid cavity is altered, the axis of rotation can be considered to pass through coraco-clavicular ligament. Right? So the scapulo-humeral mechanism, abduction of the arm includes rotation of the scapula as well movement of the at the shoulder joint, right? That is a very famous wing nut rotation of the scapula, right about the upper and lower fibers of the trapezius. So multipennate acromial fibers of the deltoid are the chief abductors at the shoulder joint, but acting alone, deltoid will tend to raise the humeral head upward, as is brought about in shrugging the shoulders rather than abducting it. Supraspinatus starts abduction and holds its humeral head against the glenoid fossa, while the subscapularis, the infraspinatus, and the teres minor exert a downward pull on the humeral head. At about 90 degree of the abduction, upper part of the articular surface of the humeral head is completely utilized and lies edge to edge with that of the glenoid fossa. It's a very important, sentences. Lateral rotation of the humerus is needed to provide a more articular surface into play and permits abduction to continue beyond this point. So beyond 90 degree, what occurs? Lateral rotation of the humerus. As before that, complete occupation of the glenoid cavity by the upper part of the humeral head articular surface is taken up. Not more than 120 degree of the abduction is possible at glenohumeral articulation. Beyond this point, abduction, as is in bringing the arm vertical beside head, requires scapular rotation that makes glenoid fossa face upwards, carried out by trapezius and serratus anterior. I mentioned already, discussed already with you, except during about initial 30 degree of abduction, glenohumeral movement and scapular rotation occur simultaneously, and their ratio being 2 to 1. What does that mean? For every 3 degree of abduction of arm, a 2 degree abduction occurs at the glenohumeral joint, and a 1 degree abduction occurs by rotation of the scapula. So now the blood supply of the shoulder joint. The shoulder joint is supplied by anterior and posterior circumflex humeral arteries and the suprascapular arteries. These interior and posterior circumflex humeral arteries. Here you could see this. These are the, this is the anterior circumflex humeral artery. This is a posterior circumflex humeral artery. And these are the branches of the, third part of the this axillary artery. This is axillary artery, first, second, and third part. And the suprascapular artery is branch of the thyrocervical trunk, first part of the subclavian artery. This is a suprascapular artery, right? This, you could see this. This is the suprascapular artery coming from this thyrocervical, cervical. This is a thyrocervical trunk. This is a branch of the first part of the subclavian. This is a subclavian artery, right? And innervation of the shoulder joint. The following nerves supply the shoulder joint, posterior part of the brachial plexus, and the suprascapular, lateral pectoral, and axillary nerves. So in the last, these are the bursae around shoulder joint. Very important. Some of the bursae are very important. So bursae around glenohumeral or the shoulder joint. Several bursae are situated near the shoulder joint. Bursae are found where tendons rub against the bone, ligaments or other tendons, and where the skin moves over a bony prominence. The bursae around the shoulder joint are clinically very important. Why? Some of them are in communication with the joint cavity, for example, the subscapular bursa. As a result, if such a bursa is open, it means entering the cavity of the shoulder joint. You could see, right? So this is a subscapularis bursa over here, right? This is a subscapularis muscle, and this is the our subscapularis or subtendinous bursa of subscapularis. This is the one bursa talking about. This is in communication with the joint cavity. And then this subtendinous bursa, few words more, placed between the tendon of the subscapularis and the neck of the scapula. The bursa protects tendon where it passes inferior to the root of the coracoid process and over the neck of the scapula. I told you already, it mostly communicates with the cavity of the shoulder joint through an opening in the fibrous layer of the joint capsule. So it is really an extension of the shoulder joint cavity. You see again, right? This is the subtendinous bursa of the subscapularis, right? This is in communication with the joint cavity. And the last, right? Bursa, this is a subdeltoid bursa, the subacromial bursa, right? So it is situated between the acromion, coraco-acromial ligament, and the delta superiorly, and the supraspinatus tendon and the joint capsule of the shoulder joint inferiorly, right? So I can zoom in for you over here, right over here, right? You could see this, right? This is over the subacromial bursa or the subdeltoid bursa, and inferiorly is the present supraspinatus blending with the joint capsule, and superior to this bursa is present the deltoid and the acromion, right? This is the superior aspects, and then also this coraco-acromial ligament. So in this way, it facilitates movement of the supraspinatus tendon under the coraco-acromial arch and of the deltoid over the joint capsule of the shoulder joint and the greater tubercle of the humerus. So this bursa, this one, it facilitates this movements of the supraspinatus and of the deltoid. Its size changes, but normally does not communicate with the cavity of the shoulder joint. I thank you very much to listen and watch my lecture on this shoulder joint. So I'll be coming up very soon with the next topic, clinicals of the shoulder joint. So support me by subscribing and sharing, like, and do comment below. Bye.